of the founders of SICOT Pioneer, and it is indeed a pleasure to welcome all of you logging into this webinar from all around the world. Now, in the COVID world of non-contact domains, we've certainly embraced digital competitiveness with the launch of SICOT Pioneer, and through this platform, we've done over 35 events and have had over 60,000 views from 110 countries from around the world. So a big thank you for joining us and following us. Now, today's webinar is in collaboration with the Italian Society of Hand Surgery and will focus on scaphoid nonunions. I would like to sincerely thank our moderators, Professor Ferdinando, who's worked very hard to put this together, along with Professor Margaret Falk from Hong Kong, and for making this happen, and the stellar faculty who've given up their precious time on a Sunday to guide us and teach us on this webinar. We shall try and make this as interactive as possible, so do post in your questions, and if you can't join us today, then you can access it via our on-demand platform as well. Once again, a big thank you to the people who make it happen behind the scenes, Gauri Trivendran, Sufyan, the SICOT Pioneer team, and to all of you for joining in from around the world. Hopefully you'll enjoy the next 90 minutes. Thanks a ton. Over to you, Margaret and Ferdinando.
Thank you, Vikas. So let me introduce Professor Ferdinando de Lorenzo, who is going to speak about, who is the Vice Chairman of the SICOT Committee of the Hand Surgery. So, and he is going to give a very short introduction about the society, the Italian Society for the Surgery of the Hand. So over to you, Ferdinando. You have muted. Ferdinando, you have muted, sorry.
Yes, my presentation is Soflan that launched my presentation, is right. Okay, you listen to me?
Yes.
Okay. It is a great honor for me to represent the Italian Society of Hand Surgery. I thank of behalf of the president who could not participate, SICOT for allowing our society to participate in this event, and Dr. Falk for having contributed to make it happen. Our story begins at the beginning of the Italian orthopedics with the Professor Alessandro Codivilla, first director of the Rizzoli Orthopedic Institute. The first learner of Codivilla orthopedic was Professor Putti, one of the founder of SICOT in Paris at the Hotel Crillon, 19 October 1929. He bought a build one of the two institutes where I work, the Putti Institute for the Treatment of the Infection, the Codivilla Institute for all orthopedics from fractures or to prosthetic. This is my city, and here you see my hospital is there. Thanks. Two of Professor Putti's favorite learners were Professor Oscar Scaglietti and Professor Augusto Bonola. And SICM was officially founded in Florence on March 19, 1963, thanks to the speech of foundation of the new society of Professor Augusto Bonola, which originates from SIOT, Italian Society of Orthopedics, thanks to the profound work done by Professor Scaglietti. The founding partners were, in addition to Augusto Bonola, Giorgio Brunelli, Aldo De Negri, Leonardo Gui, Germano Mancini, Umberto Mangini, Ezio Morelli, and Filippo Pericone. Professor Augusto Bonola is appointed president. Professor Brunelli here with Professor Levi di Montalcino, Nobel Prize for Neurology. 80 December 1962, the first symposium of hand surgery takes place in Orthopedic Trauma Center in Florence. 19 March 1963, the second symposium on surgery takes place in Orthopedic Trauma Center in Florence. 22 January 1964, the first issues of the Rivista Italiana in Chirurgia della Mano is the journal, our journal, is published. In the same date, the first Italian Congress of Hand Surgery was organized in 1964 together with the SICOT, and subsequently the 4 international congress with the many international hand surgery surgeons. Bonola was co-founder of the Italian Society of Hand Surgery, of which he invented the emblem, inspired by the pattern hand of the Hospital Institute of Modena, from the gate of the blacksmith Malagoli of the former Sant'Agostino Hospital in Modena, imaging of the anatomical of Padua, Giulio Caserio, 1552-1616, in the act of dissect a hand, and the phrase that Bonola used for the Society of Hand Surgery, rimatur manum apta manum mens erue mentem. I try to translate this phrase in English, is the trained hand dissect the hand of mind to disclose the mind. The logo of the society, and I tried this traduction. SICOT, this is the precedents from 1963-2021. The SICOT published a journal, Rivista Italiana di Chirurgia della Mano, with 3 annual issues and organized a national congress every year. It is part of the International Federation of Society of Hand Surgery and the European Federation, and as an Italian hand surgery study group, is affiliated to SICOT, Italian Orthopedic and Traumatologic Society. SICOT Hand Center in Italy, managed by SICOT members. And this is emergency. Sorry, one behind. Sorry, one behind. Sorry, it's not, is incompleted because the SICOT thanks SICOT for the Culture's invitation. I'm sorry. And then let's see you.
Thank you, Ferdinando. So yes, so without further ado, let's go through our. We are very privileged to have basically hand surgeons from all over the world, as well as hand surgeons from Italy, to give us a talk on the Scaphoid Nonunion management. And let's start with the abstract first. So we have one abstract that we've chosen for this webinar, and is actually on Elion Badara Diouf from Senegal, and he's going to talk about surgical management of Scaphoid Nonunion. So maybe Dr. Diouf, could you please share your screen and start your talk?
Dr. Diouf, we are waiting for you to share your screen to start your talk.
Excuse me, I'm here.
Please do share your screen and you can start your presentation.
Okay.
And your camera is off as well at the moment. If you could kindly put that on, that'll be great.
Okay. Sorry. It's okay for you?
Yes.
Okay. Non-union on the scaphoid is the most common complication of the fracture of this bone. Despite the development of radiology, which allows early diagnosis and treatment, about 10% progress to cerathromatosis. Untreated, this latter leads to ineluctable osteoarthritis. Several techniques have been developed, from non-vascularized grafts to those dependent on a radial vascular network, not to mention palliative treatment. The aim of our study was, through 19 observations, to evaluate the anatomical and functional outcomes of the management of nonunion of the carpal scaphoid. For that, we have a retrospective study. This was a retrospective study from January 2011 to October 2018. 19 men and 1 woman with an average age of 28 were affected. They present a nonunion of the scaphoid stage 2A of Allo, stage 1, and associated with a perineal dislocation of the carpal bone. Average consultation time was 6 months. The outcome assessment was based on consolidation and functionally on the Mayo-Risk score rating. The anterior approach was performed in 12 cases, and 5 cases it was posterior. 2 times it was anterior and posterior. The radius was used 13 times as a bone graft collection site, 3 of which were vascularized. Fixation was made by means of pins for the most part. 11 times bent and by screws, supplemented by a plaster, by a cast, by a Trojan cast in 18 cases. Consolidation was effective at 75 and 90 days. Functionally, we achieved 42% external resultant, 26.4% good results, and 31.6% average resultant. There are some cases, a schoolboy, 16-year-old, left in the left wrist 1 month after the surgery with pins. And the second case, a schoolboy, 21 years old, with a rise with 5 months with arthrosis, and after the bone graft non-vascularized with a screw. You have this picture here. And this one, we have a dislocation with a carpal bone. That's why we put spin in this side. And the last, we have the second one with a good Mayo's score with, and the contralateral wrist with dislocation. And longer, we have arthritis at 3 years. In the description, can say that our management of nonunion of the carpal scaphoid was essentially based on conservative treatment. 18 cases out of 19 by treatment and bone grafting with consolidation in 15 patients. Revision by vascular graft in 1 and iliac graft revision by vascular graft in 1 and iliac graft in the other result in consolidation in 11 patients. The advantage of radial graft harvesting is that it only requires a single approach with a single operational anesthesia. However, there is no doubt that iliac graft treatment offers more advantage in quantity and quality. Our consolidation rate, which is 80%, correlates with those in the literature, which vary from 70 to 90. This rate can reach 92 to 100% in departments that have used vascularized grafts. However, the use of this latter would only be justified after 1 or more conventional transplant failures and in the absence of osteoarthritis. The existence of a perineal carpal dislocation constitutes a dilemma in their management: conservative treatment or resection of the first row of the carpal bone. Certain forms greater than 6 months justify non-conservative treatment in relation to the risk of injuring the head of the capitate during difficult reduction maneuvers with often disappointing long-term results. In conclusion, we can say the treatment of scaphoid nonunion based essentially of a provision of iliac or radial cortical graft and fixation. Association with perineal dislocation makes management difficult and long-term outcomes. Thank you for your attention.
Okay, thank you. So there's just two questions from you to you. The first question is, do you see that in the perineal dislocation cases, is the outcome similar to the ones with just a scaphoid nonunion, or do they tend to be slightly worse? And the second question is, when do you decide to use radial bone graft versus iliac bone graft? And especially you said that in the literature, it seems as though the iliac slightly better.
Okay. Sorry, I don't get you for the first question. Can you repeat, please?
Yes, the first question is about, so there are some cases which is perineal dislocation, and there's some cases associated perineal dislocation, and there's some cases that are not. So is there any difference in the outcome?
Okay, for the patient. So I'm going to answer for the second question after I'm going to see for the first question.
Mm-hmm. Yeah.
When I use a bone graft vascularized or not vascularized, it's dependent of the during of the fracture, because we have some patients who come in the hospital at 3 months ago about the accident, and then we decide to put the bone graft vascular, because the bone is not in best quality. We have necrosis in the debut, because for the second question, all patients have a good we can see in the Mayo risk score for the first question. All patients have a good score from 65 to 100. It's the middle in the 65 to 100 for all patients. So we haven't got worse and bad results, bad outcomes for the outpatient. It's the same results for all. Okay.
Thank you. So for the second question is about in the non-vascular, when there's no AVN, when there's no vascular necrosis of the scaphoid, would you use radial bone graft or would you use iliac bone graft?
I don't iliac bone grafts. This one.
Helen, which one? Iliac bone graft.
In the second question, when I have a necrosis in the carpal
when
bone,
there's no necrosis.
No necrosis.
Yes.
No necrosis. Yes, I put only. I prefer to put radial graft there with cortical with no cortical when I have necrosis.
Okay, thank you. Okay. Yes. So yeah, thank you all, and yes, and please stop sharing the screen so that we'll start our webinar. So maybe Ferdinando, will you introduce the first speaker?
The first speaker is Giancarlo Caruso, right? Okay, I presented Dr. Giancarlo Caruso, hand unit hand surgery at the Piero Pelagi Hospital in Florence, Italy, secretary of the Italian Society of Surgery of the Hand. Please, Dr. Caruso.
Good morning to everyone. First of all, I want to thank SICOT for kind invitation. Then, how do we get a scaphoid nonunion? We can have scaphoid nonunion when we have a delayed diagnosis or inadequate treatment, but also we can have scaphoid nonunion if the initial care was timely and appropriate. Scaphoid nonunion rate is about 15% of the scaphoid fracture after conservative treatment, but is higher, 50% when displacement is more than 1 millimeter using advanced imaging. What the scaphoid is so important? Because it's a stabilizer bridge between two carpal rows, is almost completely covered by cartilage, has a terminal vascularization, and the proximal pole with a little hyaluronate has a poor healing tendency. We speak of non-union of the scaphoid when we don't have union after fracture after 6 months. Between 3 and 6 months, we speak of nascent non-union, and within 2 or 3 months, we speak of delay in union. The X-ray is the first step for understand the problems of scaphoid union. We can see obviously the line of non-union, but is important for understand the carpal height and the scaphoid shortening. We can use the X-ray for see also other signs as radial osteophyte. And it's important to compare the X-ray with contralateral wrist. CT scanner is used for deformity, for evaluation of arthritis, and for preoperative planning. MRI we use principally for understand the avascular necrosis of proximal pole. Probably the most important imaging is three-dimensional CT scanner for preoperative planning. Scaphoid nonunion indeed is a complex three-dimensional deformity. The Al-No classification is probably the most useful for understand the natural history of the scaphoid nonunion. In stage 1, we have no deformity. In stage 2, incipient bone resorption. In stage 3, arthritis. And in stage 4, proximal pole necrosis. In stage 1, we have no deformity. We speak of fibrous stable nonunion. Fibrous stable nonunion can be symptomatic or non-symptomatic, but twice should be repaired. How? With percutaneous debridement and reaming and screw fixation, and often with arthroscopic assistance. In stage 2, with incipient bone resorption, but without DISI, dorsal intercalated scapholunate instability, 2A, we can use bone graft. Bone graft can be cancellous or corticocancellous. Matthews procedure can be appropriate in this stage. In stage 2B, including DISI and humpback deformity, and in stage 3 with arthritis, we have no choices. Corticocancellous bone is the gold standard for the treatment. Fernandez's procedure can be appropriate in this stage. It's important the preoperative planning, the approach is palmar. A good tip can be use of KI wire as a joysticks. Corticocancellous bone must be used for correction of scaphoid axis and height of scaphoid. If we can't correct DISI with application of graft, we can use KY radiolunate for 8 weeks. This is a case report. You can see above in the left the scaphoid nonunion, in the middle contralateral scaphoid, and in the right above DISI deformity, and below humpback deformity. Intraoperative image above in the left, K-wire used as a joysticks, and application of a graft in the middle, and in the right, the donor site iliac crest. Below, 2 months after operation with 3 K-wires, and X-rays control and clinical control 1 year after operation with Mayo wrist core excellent. What about stage 4? In stage 4, with a vascular pole necrosis, vascularized bone graft have an union rates higher than a non-vascularized bone graft. Regarding incidence of union, distal radius and iliac crest bone have similar union rates, but iliac crest grafts have more complication at the donor site. Regarding the device used for consolidation, screw and K-wire have similar results, but better than no fixation. In the last years, is spreading this system for reduction, a plate system, but the plate system needs the outcome longer, the more outcome longer. Then, after the Alno classification, we can have scaphoid nonunion advanced collapse, snack wrist. And our aim in snack wrist can't be scaphoid union, but we must use salvage procedures for avoid the progression of arthritis, as a proximal row carpectomy or four-corner arthrodesis, or a substitution of proximal pole of scaphoid with prosthesis. Then, in our journey from fibrous nonunion to a vascular nonunion, we can say then more than 90% of scaphoid nonunion heals using bone grafts. And we must remember that scaphoid nonunion is a complex three-dimensional deformity, and the union rates depends from stability and site of the nonunion, age, very important, age of the scaphoid fracture, and type of treatment and vascularization of the scaphoid. Thank you. Thank you very much for your attention.
Thanks, Giancarlo. Very good introduction to the problem of the non-union scaphoid. I have only one question for you. Which is your step when you find one non-union scaphoid? Is a pole, proximal pole, of course, you all remove, but you sometimes use the graft, but you not use the graft, vascular graft, or only a graft without vascularity?
It's important for us the MRI. After MRI, we try to see the widely of the scaphoid bone, and if the vascularization is very bad, we see other signs as age of scaphoid fracture is important, age of scaphoid fracture, and vascularization of scaphoid pole. Pole is very little, probably we use revascularization procedures. If the bone is higher and the age of scaphoid fracture is so not old, we try to use bone graft. And in the recently, we use more radial bone graft than iliac bone graft for the problems I have just explained.
Okay, thanks. Somebody of the panel have some question, please?
If no, then maybe we'll go to the next one. And remember that the attendance, you can also post questions to the website, and we'll be able to answer it either after the presentation or at the end of the presentations, at the end of the webinar. Okay. So we'll start with our next speakers. Then is our Professor Mohammed Ali Al-Bayati, who is the Emirates Consultant Hand Surgeon to City's Hospital and Iraq, and also the Associate Professor to the Medical Technical College, Farad Kiti University, Baghdad, and he's the SICOT National Representative for Iraq. And his talk is on open management for scaphoid nonunion.
Thank you, Margaret. Good morning for you all, and thank you for all your effort. Should I share screen now?
Yes, please.
Can you see my presentation?
Yes.
Yes, okay. So my share is talking about open approach to nonunion of the scaphoid.
Can we do it in the slideshow? Sorry, could we have it in the slide?
Yeah.
Thank you.
Yeah. So nonunion is by conventional terms is a non-healed scaphoid by 6 months after injury. The rate is about around 10% to 15% of all fractures. Whereas a delayed union is a time frame for below less than 6 months. The avascular necrosis of the proximal part is always a threat. These are several usual pictures we see. It could be in the waist, in nonunion fibrous. It could be in the proximal pole. It could be comminuted, and it could be with cystic changes and angulation and the gap. The causes also has been talking about. It's mechanical and biological because of the anatomy, blood supply, and biomechanics of the scaphoid, which give this peculiar causes of to go into nonunion, especially in the proximal pole. So most of the cases of scaphoid fractures will heal. Some of them will not, and those will be a trouble. So we need to select our cases, study them, and select the indication for those who will not unite or who is going to or are established nonunion. We need to follow the displacement, the time of the after before injury, the preliminary management. All this should be considered, and if the scaphoid proved to be going into nonunion, then we could interfere and to put a graft and fix. The mainstay treatment of nonunion of scaphoid bone is a graft and stabilization. This was pioneered by Mathieu and Rose from the 60s. Then vascular bone grafts were introduced and gained more logical popularity nowadays. We have several possibilities of using a vascular bone graft with the dorsal approach from the capsule, from the radial artery branches, or on the volar approach from the volar radius and coronary quadratus pedicle bone grafts. It depends on the personality of the fracture and the preference of the surgeon. Several types of fixators, which is mandatory here, and immobilization were used. Headless compression screws used widely nowadays to fix the fracture bone, correct its deformity, provides compression, and allows earlier movement of the wrist. K-wire fixation provides comparable results, but mostly with a longer time of immobilization. And obviously, it is cost effective. These are several types of the compression screws of the market use. The volar approach, we have several approaches. We have the volar palmar approach, we have the dorsal approach, and we have the mini dorsal approach with ligament sparing proton. Each of these approaches has its own merits, and it fits type of fracture and the experience of the surgeon. The volar approach preserves the dorsal blood supply to the scaphoid through the bed of the flexor carpi radialis muscle, and the volar tough capsule, which exposes you need to expose the fibrosity of the scaphoid at the scaphotrapezium joint. We apply a bone graft and reduce the correct angulation, fixed by K-wire or headless screw, and a plaster of Paris remains for several weeks as well. The indication is best exposure for the scaphoid at the distal and waist part of the scaphoid, for comminuted fractures, for fixation, open reduction and fixation, and for putting one graft into non-union scaphoid. It fits all these demands. This is the general approach. You plan the incision along the flexor radialis muscle, and we need to know our landmarks, the tubercle of the scaphoid. We have to put in mind the median nerve, the radial artery, and then we expose the capsule. We might need to ligate a branch of the radial artery here, and then expose the scaphoid ligament as well for the introduction of the screw and K-wires, expose the fracture, push the graft, and fix. And then we need to close the palmar ligament, the capsule of the scaphoid trapezium joint, and the sheath of the flexor radialis tendon. These are how it looks, preoperative and post-operative, with the screw. And a union, as can be seen, is achieved on the photos. This is with K-wire fixation. And this is a post-operative 3 months, 4 months post-operative movement of this. The model approach, the dorsal approach, is good for the proximal fold of fractures. It's a 4 centimeter distal tubercle between the third and fourth compartment. We size the thin dorsal capsule, we insert the screw fixator and a plaster of Paris as well for several weeks. The indication it is for the proximal fold, for the excision of the proximal fold fragment of non-united, chronic, and bone grafted also for the non-union. This is the planning of the surgery. We need to look for the cutaneous branch of the radial nerve and preserve it out of the wound, and the tendon of the flexor pollicis, extensor pollicis, the longest muscle, preserve it and take it to the radial side, and then the capsule will be exposed and incised. And then the fracture is exposed. Here we need to flex the wrist so that identify the scaphoid ligament and to preserve it. And then by acute flexion, we introduce with the use of the CR, of course, we introduce the screw over the guide wire and fix the proximal fold, which is clear here. Close the compartment and we close the sheath of the tendon. The indications are for unstable or we have the mini open dorsal approach, which is indicated for unstable or minimally displaced fracture more than 1 millimeter. The relative indication is non-displaced fractures in demanded hand for short immobilization. Many people, many patients, they hate the idea of using the plaster of Paris for more than 8 to 12 weeks. So this will probably give better stability and less necessity for delayed immobilization. It is not indicated in comminuted fractures and when the bone graft is needed because the exposure and the field is rather limited. This is how it is done, short incision. We need to look for the flexor of the flexor pollicis longest tendon and preserve it. And through a small incision of the capsule, we locate the proximal fold and we insert the screw over a guide wire. And this is how it should look with the CR. In summary, bone graft and stabilization is the gold standard treatment of non-union of the scaphoid. Water approach is good for waist and distal fractures. Dorsal approach is good for proximal fold fixation, and mini open dorsal approach for selected cases. Vascular bone grafts are logically more popular, provides relative and better results. Centrally applied headless compression screw provides reduction, stability, better range of motion, and shorter immobilization period. And thank you very much for listening.
Thank you, Professor Al-Bayati. There's a questions from the audience. Is how do you control the sufficient reposition of the disc or a disc, and how do you fix or stabilize the scaphoid lunate reposition? Do you use KYs or screws or anything like that?
In case of dislocations?
No, in case of that there is a disc, yeah. That's it. Sometimes you see it.
Yes, sometimes if you see that the lunate is unstable, yes, you use an extra KY to fix the lunate to the distal end of the radius. Yes, the radius. Yeah.
So do you use so you stabilize the lunate first before you put in the bone graft, or how do you do it? Or you do it at the end?
Maybe beforehand, so that I can use it to locate the scaphoid carefully and nicely. Yes. Okay. Because thank you. If the lunate is good, the space of the scaphoid will be good.
Yes. Thank you. Yes. That's how I do as well. Yes. We'll stabilize the lunate first. Yes. Yes. And you prefer to use KY? You would prefer to use screw instead of KYs for your fixation?
Actually, I prefer, but in fact, we use KYs more because it's cost effective. Yes. In Iraq, it is cost effective. Yes.
Thank you.
Yes.
Okay. Yes.
And okay, we continue.
Yes.
The next speaker is Dr. Pierluigi Tos, Director of the Hand Surgery and the Reconstructive Microsurgery Unit at the Orthopedic Institute Gaetano Pini, Milano, Italy, President of the Editorial Planning Commission of the Italian Society of Hand Surgery, and talk about vascularized bone graft in Scaphoid Nonunion. Please, Dr. Tos.
Thank you, Ferdinando. Thank you, Margaret. Thank you to all the SICOT for this kind invitation. It's my honor to be here with you and talking about vascularized bone graft in Scaphoid Nonunion. And I come from Milan. I think all these things you know about my city. We have two kinds of vascularized bone graft, pedicle and free. From the pedicle, we have from the distal radius, from the volar side, Kuhlmann and Matulan. For the dorsal side, the Zeidenberg procedure, that is between the first and the second intercompartmental retinacular artery. And we have also the dorsal graft base and the fourth and the fifth tensor compartment. From the second metacarpal, we can harvest our bone, or we can have free flap from the medial femoral condyle with the cartilage or the iliac crest. These are the percentage of union we can have from the first, second intercompartmental artery, or the volar carpal artery, or the medial femoral condyle. So, which is the aims of the surgery: regain the length, regain the alignment, have the stability, have a compression, better osteogenic potential, and improvement of the vascularization, if it's possible, with something that is alive. Which are the indications? This is a big issue. We can talk about that. There are no really strict indication to vascularized bone graft, because we know that not vascularized bone graft is the gold standard for the scaphoid. But we have some cases that are really difficult. In difficult scaphoid nonunions, it means long-standing proximal pole, extensive bone defect with humpback deformity, a vascular necrosis that, in my mind, is the abscess of bone bleeding during the surgery, one or multiple previous surgery, and a combination of these factors. So we use this graft only in these cases. We use the Al-No classification, as Dr. Caruso showed us, and these are the two main indications of our vascularized bone graft. Obviously, it depends from where is the problem in our scaphoid. So if it's in the middle part, we use the volar radius and the medial femoral condyle. If it's the proximal pole, we go to the first, second extra, and the medial femoral condyle with the cartilage. This is the base of the second metacarpal artery. This is a case of Francesco Brunelli. I don't use personally this technique, and has been described also by other authors. This is between the fourth and the fifth compartment. This is very useful for lunate. We do not use that for scaphoid. This is very useful. The Matulan described very well the volar carpal artery, and this is very useful for the scaphoid nonunion in the middle third of the scaphoid. And this is a case, we have a very nice pedicle and a very good healing. Another case of this technique that show us very nice results. This is a case of a female operated 2 times before, then she solved the problem with a volar graft. If the problem is more proximal, we can use the intercompartmental first, second supraretinacular artery that is very, very nice, described by Zeidenberg, and is useful for the proximal pole. You see one cases, the surgery, the graft, the pedicle, and the graft is put inside the loss of substance. Normally we put 2 Kirchner wire. There are no differences between wire and screw in the literature, and normally heal very, very well. Also in these cases that is really advanced, but the patient was very young. So you see styloidectomy and persistent a little bit of arthritis. So in this case of 17 years old, you see very well how is the evolution in the proximal pole, 2 months, 4 months, and the complete healing at 6 months. So what about free flaps? We use that routinely in difficult cases. We can use only the bone or bone and cartilage. For the proximal pole, we use the cartilage. For the middle third, when we need a big segment of bone, we use the graft, and these are the suture in the radial artery. And you see when it's necessary to have a big bone between our 2 parts of the scaphoid. So Heinz Burger and James Higgins popularized very much the substitution of the proximal pole with the osteochondral graft. I show you one cases in a 20 years old guys. This is the technique. I have no time to explain very well the technique, but we use normally the contralateral side, volar access. We substitute the proximal pole. This is with the VACT that mimic our loss of substance. Then we go to the knee. The VACTs mimic the flap, then the harvesting of the flap. Then the flap is positioned instead of the proximal pole, then the synthesis, and at the end, if we are lucky, we have a good healing and a very nice results. We do that operation in many cases only because we are one of the center doing that in Italy. Normally we have no problem to the knee, and this is another case with a very good results. Why we do not need to reconstruct the ligament? Because we give the higher to the scaphoid, and we try to preserve accessory ligament of the scaphoid to the carpus. So also the lateral femoral condyle has been described, but I have no experience of that. And the disadvantages are that it's a long surgery and we have to use microsurgery. So I know that conventional vascularized bone grafts are the gold standard in the treatment of non-union of the scaphoid, but in difficult cases, I think that there is space for the vascularized bone graft. The consolidation times seems to be a little bit lower, and the advantages are the possibility to harvest the same location for pedicle graft. Consolidation times seems to be shorter, and the indication whether there is a proximal avascular fragment. It's more complex. Small dimension of the graft are the disadvantages of this technique. About Kirchner wire and screw, we think that this is the same. So in conclusion, first, second extra for the proximal pole, volar radius for the middle third, and medial femoral condyle for the middle third, big loss of substance, and proximal pole with cartilage. And I thank you very much for your attention.
Ferdinando, I think you have unmute. You need to unmute your mic. Thank you.
Sorry, I talk because I close every time. Thanks a lot, Pierluigi, for your presentation. Very interesting presentation. And I only one little question, but as you chose the site of donor site, the donor site, why you chose? Because if you have maybe a woman, if you take a donor site in the knee, I think that is another problem, not for the aesthetic. Not, do you know that in Italy also?
Yes,
but in every part of the world, the woman is similar in every part of the world.
Yes, you're right. But really, if you need to a proximal pole, I think that the aesthetic point of view is nothing. In my mind, this is my mind. Okay, so it's much more important the proximal scaphoid than the beauty of the. Okay, we never had problem of this kind.
Okay.
Thanks.
Because you have many sites, I think that you can change. Not sometimes you can go distal part of radius, maybe metacarpal. You have many things, many possibilities.
Yes, I use the knee only if I need big bone or cartilage.
Okay. Thanks a lot. And please, Margaret.
Yes. I realize that we've missed Ali, so we're going to go back to the arthroscopic management of Scaphoid Nonunion. So the next speaker is Dr. Mohammed Ali, who is the associate professor of the orthopedics of Shams University, Cairo, Egypt, and he's the treasurer of the Egyptian Society of Hand and Microsurgery. So Ali, please.
Thank you, Dr. Margaret, for your presentation. It's a pleasure to share this nice meeting with the experience in this subject. I'll talk about the new technique, which is arthroscopic management of the Scaphoid Nonunion. Okay. During hearing our colleagues, we found that there are no gold standards in the management of Scaphoid Nonunion. As we have seen that it started by bone grafting, and then recieve, who used the corticocancellous, cancellous graft, and then Fernandez has introduced the corticocancellous graft, and the new techniques using the plating techniques and the free graft that are taken from the medial femoral and recently lateral femoral condyle. So we tried to search the literature, systematic reviews, and we found that different methods show different consolidation rates, reaching from, as we have previously seen, 80% bone grafting without fixation, and fixation with bone grafting non-vascularized reaching up to 84% or 88%, and reaching up to 90% in cases of vascularized bone graft. So new technique, which is the arthroscopic method of management of the Scaphoid Nonunion, have been introduced through the last 5 years, as we can see, with a very high union rate reaching up to 97% in a shorter duration, which can reach from 8 to 10 weeks. And so this is why we try to use this technique in most of our cases. It's less invasive. It has a better assessment of the fracture site. We can see it by magnification reaching up to 12 to 15% of the normal. I think it's reproducible for those who are mastering the arthroscopic technique. And also we can identify associated pathology. And it has decreased morbidity for the vascularity of the other parts of the scaphoid, and also that we don't open the capsule, and less stiffness and less adhesion of the open approaches. Our technique is, in the movement technique, we use the traction system, and we use a scope of 2.7. The first important part in our fracture is to correct the deformity. Especially most of our cases are coming late, cases with humpback deformity and sclerosis. The key part in this arthroscopic management is to correct this humpback deformity. And as Dr. Fogg has stated before and pointed on the importance of the radioleonate wire, that can help the reduction of the proximal pull. So what we do is first we try to flex the wrist fully, and then we insert a radioleonate wire under the arm. And then to control the distal pull, we try to insert another wire, which is the scaphoid. In such a way, we aim to restore the length of the scaphoid and to clarify the fracture site. Then we go by traction. Usually we start by dry technique, as that has been introduced by Del Pinel from Spain a long time ago. And usually the fracture site is apparent as an interruption in the cartilage, as we can see. And then we probe it to release, because it is usually filled with fibrous tissue. So we have to curate all this fibrous tissue, as you can see. We use shavers and curate. Afterwards, we try to insert our bone grafting using the cannula of the arthroscopic system, or sometimes we use the cover of the needle or the syringe, where we can insert a graft. Usually we use the iliac bone graft. Why? Because usually we need a very large amount of bone graft, which is reaching about 3 times the size of the defect of the scaphoid. The defect in the Scaphoid Nonunion. And also by impaction, this takes larger amount. And we think that also it is of a higher quality than that of the rate. Then we go to fixation, and most of our cases we fix them with wires. And then we close our wounds just with simple sutures, and in some cases we leave it open. Our post-operative protocol is we do cast immobilization afterwards, and usually we do our follow-up by CT scan every 4 to 6 weeks. Usually at 6 to 8 weeks, we try to remove our splint at the morning and apply it at night. This helps the patient to have an early range of motion. And then after union, patient starting active and passive exercises. We can show 2 cases. The first case is a 22 years old university student who is right dominant, and this is his right wrist, and he's not a smoker. He suffered from distal scaphoid fracture after falling out of stretched hand 2 years ago. As you can see, his CT scan, because it's 2 years old, I think it's longest standing case. You can see the sclerotic part and the defect and the humpback deformity. So we corrected it, and at 6 weeks, really at 1 month and a half, we have complete consolidation, as you can see in this CT scan. Another case, which is a 50 years old carpenter, right dominant, with a fracture of about 3 years. Maybe it's not quite apparent in the plain X-ray, but it's very clear in the CT scan, as you can see, with much sclerosis, large border defect, and large humpback deformity. Usually this is the immediate post-operative X-ray with our fixation by T-wires, and this is his post-operative CT in 7 weeks duration with complete union. So afterwards, we try to search the literature to see available comparative studies between both techniques, open and arthroscopic, and we only found a retrospective study and not a prospective study, which was published in 2018, comparing both groups, including about 62 patients, and we can see that the difference is not that much between open and arthroscopic. They are of the same cost, but the arthroscopic one has more increased operative time, can reaching up to 2 hours, 2 hours and a half. But the arthroscopic group has a better range of motion. I think this is related to the early consolidation and so early mobilization. But correction of the scaphoid length in comparison with the contralateral side was better in the open group. But both have, they state in their case that they have both same union rate and near similar clinical outcome. So our take-home message is that arthroscopic grafting technique is less invasive, and it is a very good alternative to open grafting for those who are mastering the wrist arthroscope. It has a high learning curve. It's beneficial, especially when we have associated wrist pathology, but we don't recommend much in comminuted cases or cases where there is EVN. Thank you.
Thank you, Ali. So, thank you. It's a great talk. So, may I know this? I've got two questions. One is from the audience and one's from me. So,
sure.
So do you now, is that your preferred choice to use arthroscopic bone graft for all the Scaphoid Nonunion then? Is there any cases?
Sorry, can you repeat it?
Is that your preferred choice? Is there any cases that you won't use arthroscopic bone graft?
What I understand that you mean, this is my preferred choice? Yeah.
Yes.
Now it is my preferred choice for all Scaphoid Nonunion. I do them arthroscopically.
Okay. And you will, yeah.
Intraoperatively, I usually assess first the vascularity of the scaphoid. So I have a video, but it doesn't work at this time, but I can share it now if you would like. To show that, I would like to show it. Just a second. Okay. Just to show that after shaving, we try to enter with key wires to assess the, you see the key wire and see that there are vascularized ends of the both ends of the scaphoid, and then afterwards we try to apply our graft. So I have not very good experience with cases with AVN. I have a few cases with union rate 50%. I have some of these cases that are united and others that didn't unite really. When I use the arthroscopic method as have been recommended by P.C. Ho from Hong Kong. Yeah, I don't have the same union rate in cases of AVN as P.C. Ho really. And I hope I would like to do all arthroscopically really.
Yeah, thank you. Yes. Yeah, thank you. There's another question from the floor is about, do you use PRP or BMP or anything to try to increase the bone union rate?
No, I don't use this. I tried to use it in other fractures, but I didn't have good results really. Yeah. So I usually I limit its use because normally evidence-based medicine doesn't have evidence regarding its use in fractional anemia.
Yeah. Thank you. Yes. Yeah. I don't have either much experience on PRP and BMP as well. Yeah. But yeah, thank you very much. Thank you for the presentation.
You're welcome. You're welcome.
Yeah, thank you. So next is Ferdinando. So maybe I will introduce you since you're going to give the next talk. So so next we'll have Ferdinando, who is the, as I mentioned earlier, he is the vice chairman of the SICOT Committee for the Hand Surgery, as well as the founder of the Italian Italian Society for the Surgery of the Hand, for Context and other companies, and the SICM Committee for Training. He's also the founding member of the World Society of Bone Infections. So, and he's going to talk about the treatment of proximal pole scaphoid fractures with vascular problems.
Thanks a lot, Margaret. I hope that Soflan give my, okay, thanks.
Yes.
Thanks for inviting me to present my experience, and I will talk about the treatment of fractures of the proximal part of the scaphoid with vascular problems with the collaboration of Dr. Matlan and Dr. The mechanism of injury is usually a fall with the wrist in dorsal hyperflexion and radial deviation with the scaphoid that impacts strongly on the dorsal edge of the wrist. The scaphoid fracture is most evident among younger adults with an average age of 29 years, with the greater prevalence in the men. It's more unusual to find fractures in the pediatric or elderly population, in which the fracture of the distal radius is more likely to occur. At the wrist level, they account for about 15% of all injuries. One of the main problems, in addition to the fracture itself and the recovery time, is the high extent of nonunion, 8-10%. A big problem is anatomical in repairing of a scaphoid fracture because the scaphoid is almost entirely covered with cartilage. Think of bone repair system. The scaphoid is an intercapsular bone, and the proximal bone is entirely interarticular with difficulty in calcifying and also repair not very often. Another problem for repair is the vascularization of the end of the scaphoid. There is an artery that comes from the palmar part and another that comes from the dorsal. But the dorsal is the most important for the distal part of the scaphoid. The percentage of vascularity of the scaphoid decreases on the distal tooth. Radiography is the first examination, but at the same time, cases, MRI or CT can help in diagnosis. MRI is more important in diagnosing any ligamentous injuries. And the vascularity of the proximal pole of the scaphoid. It is the classification, but all of these fractures can have vascular problems. Another factor is instability. In fact, the scaphoid is the bridge between the two carpal supply chains, so much so that its fracture leads to a fragment. The distal one to connect to the distal chain and to the proximal fragment to the proximal chain. However, which will explain why a fracture here is still unstable, even if composite. Treatment of fractures of the proximal pole of the scaphoid with vascular suffering differs depending on the characteristics of the patient and the date of the fracture. All patients have the suffering of the proximal pole of the scaphoid documented at MRI. Fresh fracture of the proximal pole of the scaphoid is a healthy young subject without these fractures. Synthesis can be done directly. Reduction and synthesis with the arthroscopic in percutaneous proximal distal strip on the right side, the result after 60 days. Reduction and synthesis with the arthroscopic in open dorsal approach. Result in 45 days. Gradually subject, young, without risk factor, but with all fractures, synthesis shows platelet death, BNP, stem cells, and autologous form. X-ray before the treatment. Great experience of bone reconstruction also in other districts with this combination of elements. The result. No longer young subjects with risk factor, diabetic, mortal, cardiopathic, long time elapsed between the accident and the intervention. Failure of the screw or other repairing intervention failed absent. Many authors have tried to remove the proximal pole of the scaphoid and replace it with a tendon made of anchoring. But as seen on the X-ray on the left, the radial displacement of the carpal is great. Therefore, adaptive proximal scaphoid implant extrude very well the space left over from the removal of the proximal pole of the scaphoid. Abscess both in open and in abscess. 3-4 working portals and the 5-6 for the arthroscope are used. The 3-4 should be enlarged a bit and the MCL portal to view the good positioning of the catheter. Removal the proximal pole of the scaphoid. Comparison measurement between the proximal pole of the scaphoid and the abscess suspensions. Measurement with the test prosthesis. Evaluation from the MCR portal of the good positioning of the abscess prosthesis. RX control. Treatment after surgery and immobilization of the wrist is carried out for 2-3 weeks. One of the complications that can happen is the palmar dislocation of the prosthesis that has been resolved by making a palmar upload and placing a large abscess, revolving the palmar joint cup. Microsurgical treatment or pediculated graft treatment has already been treated by another treatment. In conclusion, the proximal pole of the scaphoid can also be treated with a non-microsurgical intervention with different techniques depending on the patient and the time elapsed between the accident and the intervention, both in open, both under endoscopic. Thanks a lot for your attention.
Thank you, Ferdinando. A very interesting talk. Yes. Oops. So may I ask, so a very interesting talk. So may I ask about the implant? So is there any, so you said there's complication about this dislocation. So what's the technical tips in doing this?
When I have a complication?
Yeah. No. How do you put it in so that you prevent from complications?
For prevent the complication. The complication is sometimes in the volar place. The problem, I know in my experience, every time the luxation is volar, but the approach we make dorsal. For prevention, that is difficult because you make another approach, you open the volar part and you reconstruction or tension the capsular. And this is very, very difficult. The most important question is that you choose the perfect size of the part that you reconstruction. Because if you have a little, is normal that you have the luxation, but not only in the volar part, you have in every part of the carpal bone. Maybe I see before one imagine that we have this abscess that arrive in the capitate. This is the great problem is the size, because we remove the part of the bone and we make a control before to do that, because we understand very well which is the size that is good for it. And after we control also with arthroscope if it's good every part of this part. Is a good question, but the prevention is that you do very well the system.
Yes. But any long-term, so what's the long-term follow-up? So they are quite, so.
We have many years of this follow-up. We arrived 10 years maybe. And yes, we haven't, but we discuss about the cases that is very difficult to find another question, because is all the patients, all the fracture, and the possibility to make a microsurgery is not easy. It's not easy. The choice of microsurgery is not easy. And after I say another things that have a big other problem, cardiopathic, diabetic, another question. This is, for me, is the unique possibility to reconstruction the pole proximal pole.
Okay, thank you. So, so maybe you introduce Assam?
Yeah, I introduce Jeffrey Yao. Jeffrey,
I think,
what you say?
I think Assam is next, because Jeffrey is
later.
Delayed. So
okay. Sam, I present you my friend Sam El-Khalef. Sam El-Khalef is a professor at the Department of Orthopedic Surgery and Traumatology, Faculty of Medicine, Alexandria University, Egypt, and presented as a non-union of skeletally immature scaphoid fracture. Praise Professor El-Khalef.
Good morning. Good morning to everyone. I'd like to express my gratitude and thanks to Dr. Falk and Ferdinando to let me share in this nice symposium. I'll speak about the skeletally immature scaphoid fractures in children. Carpal injuries are not common in the youngsters. Scaphoid is the most commonly fractured carpal bone, representing only 0.5% of all pediatric upper limb extremity fractures, and the incidence is about 0.6 per 10,000 children less than 15 years. So it is relatively rare. Why it is uncommon? Scaphoid ossification center or starts to appear at the 4th year of life in boys and in the 5th in girls, and concludes by 13 and 15 years, while the capitate and hamate starts in the 1st year, and the triquetrum starts between 2 and 4 years. Before ossification center appears, the scaphoid is almost cartilaginous. After appearance of the ossific nucleus, the thick peripheral cartilage that envelops the ossific nucleus provides a cushioning effect. So a greater force is needed to fracture this cartilaginous scaphoid than that in the immature, than that of the mature adult scaphoid. Also, there is usually a protecting earlier distal radial metaphyseal failure, leading to a buccal fracture or a failure at the relatively weaker point at the distal radial epiphysis. So the distal radius break or slipping of the distal radial epiphysis usually absorbs the shock and protects the scaphoid and other carpal bone from being fractured. Therefore, scaphoid fractures are not common in the youngsters. The mechanism of injury is usually a fall on outstretched hand with an element of compression on hyperextended wrist with radial deviation. The site and orientation of the fracture usually is determined by the degree of radial deviation of the wrist at the time of the impact. How can we classify? We can classify anatomically like the adult one, fracture at the tubercle, the distal third, waist, proximal third, and so on. Historically, a study in the 1980s stated that the distal scaphoid fractures are the most prevalent type of fractures in the skeletally immature scaphoid, followed by the waist fractures and then by the proximal pool. And of course, the distal scaphoid fractures had a better prognosis than the waist and proximal pool. But more recently, Golson et al. Found that this epidemiology has been changed, and the most prevalent type is the waist fractures, constituting about 71%, and followed by the distal pool, 23%, and then proximal pool. And they attributed this change or this shift because of the early age contribution of children in a heavy contact, high energy athletic sports. Lorenzo classified scaphoid fractures in children according to their age and consequently according to the degree of ossification of the scaphoid. Type 1, the child is less than 8 years. The fracture line may be entirely cartilaginous or maybe osteochondral, and in this type we need MRI for diagnosis. Type 2, between age 8 to 11 years, and it may be an osteochondral fracture. And those who are older than 12 years, we can treat it exactly like that of adults. Regarding the non-union of skeletally immature scaphoid, we have to differentiate between two situations. A properly diagnosed fracture and managed from the start and went into a non-union, and another one which is missed and had no previous management. As with other scaphoid fractures in children, is a diagnostic challenge and can be easily missed on initial presentation and it may be overlooked or may not evident at all in the X-ray. Missed fractures may go into non-union and become a source of chronic wrist pain and disability. The important point is that sometimes with fracture of the distal end radius may occur together with fractures of the scaphoid, particularly in very violent injuries. And of course, the break at the distal end radius will take the attention, let the fracture of the scaphoid being missed, and may go into complications as delayed union and the non-union. Non-united fractures of the skeletally immature scaphoid, as that of adults, carry the challenge of development of resorptive changes and cystic changes at the fracture sites. And massive resorption may result in secondary carpal instability patterns. And of course, as we heard before, the massive resorbed part needs a corticocancellous and large part of bone grafting in order to regain or restore the normal anatomy regarding the length and orientation for a better or normal wrist biomechanics. These fractures also carry the risk of development of osteonecrosis and subsequent arthrosis due to inherent limited vascularity of the scaphoid. Also, we have to bear in mind that a fracture of the skeletally immature scaphoid needs a violent injury, and therefore most of them are unstable fractures and more prone to develop complications like volar collapse and humpback deformity. And distal tubercle may go also into non-union, and the proximal pool fracture may go to AVN. What about treatment? Shall we go for conservative management with prolonged immobilization in spica, or choose the surgical option? In my book, there is no place for conservative management. Regarding surgery, we have many options. We can use percutaneous screw fixation with or without grafting, or K-wire fixation or screw fixation by open method with or without fixation. But there is always a concern when we use a compression screw that may interfere with the development or growth of the immature scaphoid. Treatment of a scaphoid, skeletally immature scaphoid non-union, particularly those who had developed AVN collapse, humpback deformity, is a real challenge. The conventional non-vascularized grafting as Materos or Fisk-Fernandez grafting can restore the structural architecture, but they are not helping to increase the vascularity of the non-united scaphoid. While the Zeidenberg and Matula vascularized pedicle graft can help to improve the blood flow, but usually fail to correct the humpback deformity or restore the scaphoid length. Restoration of both vascularity and geometry is critical for promoting bone union and to regain the normal anatomy and the biomechanics of the wrist. The free vascularized medial femoral condyle bone grafting provides both and have proven successful in treating this problematic subset of scaphoid non-union, the medial femoral condyle. I'll present some of our cases. This is a non-united fracture of the tubercle that's managed by excision. And this is a 15-year-old boy with volar collapse managed by Materos without any type of fixation and went nicely. And there's a massive resorption with humpback deformity managed by vascularized grafting from the distal end of the radius using the 1-2 ICSRA and headless screw fixation, while this massively collapsed case managed by grafts, non-vascularized grafts from the distal end of the radius and K-wire fixation transfixing the bone and joint. and this is after removal of the wire. And this case has massive resorption with shortening of the scaphoid managed by 1,2-ICSRA vascularized pedicle grafting and headless screw fixation. This is after union, and we removed the screw to allow the normal growth of the bone. To conclude, a high incidence of suspicion and obtaining appropriate radiographs in the evaluation of a child or adolescent with traumatic painful wrist should be always there in order to diagnose such fractures to prevent complications. A good number of these fractures are frequently unstable fractures, and these unstable displaced fractures should have their initial or proper initial primary internal fixation with or without bone grafting from the start. For unstable and displaced fractures, cast immobilization alone may not be enough for such notoriously poor fractures that are more prone to develop complications. Surgical treatment of the non-united scaphoid in children and adolescents is a successful surgery without significant complications. And thank you very much for listening.
Thank you, Sam. Ferdinando?
Thanks a lot, Sam, for your great presentation. But Sam, do you think it is very important to use the vascularization graft in young people? The young people, I think that it's sufficient that you put the graft, the bone, and I think the result is good. Why you choose also the vascularization? Of course, correction, the deformity, of course. But when you have a correction, the deformity, I think that is a possibility to use only graft, bone graft that you can maybe in distal part of the radius. What do you think about?
Actually, there is no consensus for management of these fractures. And I chosen some of our cases.
He's an active member of the American Society for Surgery of the Hand, and his talk is going to be on the management of unsalvageable proximal pole of scaphoid. Jeff, please.
Thank you, Margaret. Can you hear me okay?
Yes.
Okay.
Great, thank you. Thank you so much for inviting me to participate in this great webinar. I thoroughly enjoyed it. I'm sorry, I'm a little bit late. I was on a plane flight and it was a little bit delayed. So thank you for reorganizing the talks so that I could participate. So I'll be focusing on the proximal pole scaphoid nonunion, which is unsalvageable. And I thank Professor Tos for discussing this, and Ferdinando for also discussing this somewhat to introduce the topic. But for the most part, proximal pole scaphoid nonunions are treatable with bone grafting via vascularized bone grafting or non-vascularized bone grafting. But occasionally, and thankfully rarely, the proximal pole is unsalvageable. Either the piece is too proximal, it's too small, or in the process of healing or fracture, it has fractured into more than one piece and becomes an uncontained defect. And in that situation, particularly if there's no developments of the snack wrist, and so a salvage procedure is not warranted, what do we do in that situation? And so to help frame this concept, I'll present a case. This is a 18-year-old American football player who sustained a scaphoid fracture, was treated with the screw fixation appropriately by another surgeon. And it looked quite good initially, but 5 months after surgery, you can see there's some lucency around the fracture site. This proximal pole fracture is very proximal. And on CT scan, you can see, particularly on this view, the proximal pole is not only non-united, but it's also fragmented in two fragments. And so in this particular situation, this proximal pole is no longer salvageable. So what are our options? We've already heard from our other speakers some of the options to treat this problem. One is to remove the proximal pole, but as we've heard, that can change the biomechanics and kinematics of the wrist in a negative way. Also, in this particular case, the proximal pole fragment is too large to simply excise. As I spoke about, a salvage procedure such as a PRC or midcarpal fusion would not be indicated in an 18-year-old with no evidence of arthritis. This would be overkill and not indicated. We've heard about excision and interposition of some sort of interposition of something, either silastic, but we know that silastic within the wrist can lead to synovitis. We've learned about pyrocarbon or other implants that may be used, and I think, at least in the United States, it's not popular, and I think we're all waiting for more published data on the efficacy of these implants. We heard that tendon can be used, but there's concern that over time this will collapse and lead to loss of carpal height. Scaphoid allograft has questionable healing potential. And then we heard about the medial femoral condyle trochlear graft by Dr. Tos. And I'll submit to you there are two other potential options for this unsalvageable proximal pole. And I'll focus on these three the rest of the talk. So as we heard, the medial femoral condyle trochlear articular graft has been popularized by Heinz Berger. He has published on 16 patients, 15 of those 16 healed with minimal to no knee pain. Based on personal communication with Professor Berger, he's told me that now he's done over 500 cases. So this is a massive amount of cases. And we'd love to hear further follow-up over the next few years. You saw a similar slide. This is from Jim Higgins, indicating the most important step is to maintain the scaphocapitate articulation. If you maintain this articulation between the scaphoid and capitate, you can use the trochlear cartilage to resurface the radioscaphoid articulation. But if this articulation is gone, you can't resurface both articular surfaces with the trochlear graft. My personal preference is to use the rib osteochondral autograft. This is not a new concept. It was initially described by our plastic surgery colleagues for mandibular reconstruction or nasal reconstruction. And also we know that these grafts are used in knee reconstruction as well. And Michael Sandow from Australia was really instrumental in describing the use of this technique for scaphoid reconstruction 30 years ago. And so often you'll have a fragmented proximal pole. Here's our patient that I just presented. You could see the pieces in two fragments. Once the screw is removed, you can see the proximal pole is not salvageable. And you can see the amount of gap there. So simple excision would not be appropriate. The remaining scaphoid is healthy with healthy bleeding. As we know, the blood supply is in a retrograde fashion. The approach to the rib is via submammary incision. I usually shoot for the 7th or 8th rib. And the dissection is actually quite simple and not very dangerous at all. The rib is very subcutaneous. It's a very easy approach. And you can see the border of the rib and the color change between the rib and the costochondral cartilage, which is more white. You obviously have to protect the pleura beneath the rib, but that's very simple to do with some nice retractors. So once the graft is harvested, then it's shaped it's like carving soap. We carve it down to the appropriate shape of the scaphoid that's been lost, and then it's pinned into place. And this is what it would look like on radiographs. And obviously it's radiolucent because it's cartilage. You can see the pins are holding it in place. And what you're looking for is just a 2 millimeter amount of rib for the osteosynthesis to the remaining distal pole, and the rest of the graft is all cartilage. And you can see at 24 months or 2 years follow-up that the carpal height is maintained and the scapholunate angle is maintained. And on CT scan, it may be a little bit hard to see, but you can see the interface between the rib and the distal pole of the scaphoid, which is showing good evidence of integration and healing. And this is that patient 24 months post-op or 2 years post-op with excellent grip strength. And Dr. Sandow presented or published on his technique several times in the past with good to excellent results. And his most recent poster, which was, to my knowledge, not published yet, minimum 10-year follow-up on 40 patients, 10%, only 10% underwent further surgery. So a 90% survivorship at 10 years. That's pretty outstanding. And the 10% that did require further surgery were either a partial fusion or a radial styloidectomy. We had a much more a modest paper, 3 patients at our center, same technique. And again, 0 complications with a very promising result. A common question is what to do with the scapholunate ligament, and with personal communication with Dr. Sandow and Jim Higgins has done a study to look at this, and basically the concept is to overstuff the joint by placing a graft that's slightly larger than the scaphoid that was removed, and that helps stabilize the kinematics of the wrist. The last technique, which is a relatively new technique, which is quite promising, is a technique described by Bapsam Helsan and Sanjeev Kakar from Mayo Clinic in Minnesota, where the proximal pole of the hamate, they've done CT mapping studies that show that the proximal pole of the hamate very similarly mimics the size or the contour of the proximal pole of the scaphoid. And so the proximal pole of the hamate is removed, the capital hamate ligament is very stout and used to repair to the dorsal scapholunate ligament that's still attached to the lunate. And this is replaces the scaphoid that's non-salvageable. So here's a case of ours where we had an 18-year-old elite high school soccer goalie, injured his wrist, had a fixation with the screw, it failed. The screw was removed and now it's persistent non-union with an unsalvageable proximal pole. Here you can see the proximal pole is very small, unsalvageable. Could you do a medial-femoral trochlear graft? Of course. We could also do a rib graft, but this was during COVID. And first of all, he did not want anything done with his knee as he plays soccer, and he did not want any pathology in his knee. And during COVID, we were not allowed to do any inpatient elective surgery. And so if you do the rib autograft, we usually admit the patient for 1 day just to observe to make sure there's no issues with the pneumothorax or anything like that. So we couldn't do that. So that led me to do the hamate autograft reconstruction. And this is what it looks like. You can see the gap at the proximal pole of the hamate where the graft has been obtained. And this is 4 months post-op, and you can see good evidence of healing, and the patient's doing very well clinically. So I think this is a very promising technique. I do worry about the midcarpal articulation with the proximal pole of the hamate, which is gone. So time will tell if there are any long-term sequelae of that. So how do I treat the unsalvageable proximal pole scaphoid non-union? The rib osteochondral autograft, best long-term data, but there is some concern for chest morbidity, and as hand surgeons, we're not operating on the thorax very often, so there is some trepidation there. Proximal pole hamate autograft, the same surgical field, makes it very attractive, but we don't have any known long-term effects on the carpal kinematics. And my last option is the medial-femoral trochlear graft. I think it's a very elegant procedure, but a very technically challenging procedure with 2 sites and potential morbidity to the knee, and also requires microsurgery. So for that reason, that's my third option for these types of injuries. Thank you very much.
Thank you, Jeff. Thank you for great presentation. So may I ask, I know that you said that you prefer the rib costochondral graft, but how about in a skeletal immature patients? Would that make you have a change in preference, or would it be the same? Can't hear you. I think you've muted yourself.
Sorry. I don't think there's any contraindication in doing this procedure in a skeletally immature patient. I would be more concerned about doing the hamate in a younger patient because, again, with 80 years of altered kinematics in the wrist, I think there's a potential issue with that. And so for that reason, I would much more rather use the rib autograft. I think the morbidity with that is so minimal. But I do worry about the morbidity to the knee as well as to the wrist with the hamate graft.
Okay, thank you. Yes, so I think time is running out, but then let me try to see if I can share a very quick case with you guys so that that will wrap up everything. So hope that you can see this. So this is a 13-year-old boy who is active in sports, especially rugby. So have right wrist pain for months, after, basically after he said it's a trivial injury of the rugby game. And this is X-ray that is presented to us when he first came in. And so we did a CT, there's a non-union of the scaphoid, and the MRI is, there's no AVN. So in that sense, what would you do?
I would like if you make an MRI, if you have one MRI, because it's important for, is young, but maybe sometimes we have the problem of the vascularity of the young people.
Yes, the people in the audience can do the poll as well. But yes, we had the MRI and it was, so I didn't show it because there's no AVN.
Okay.
So there's no AVN. So yeah, so as a skeletal immature patient, Asam, what would you do?
And allow how long a time between the fracture and that arrived to you?
Recall, he said that 2 months, yeah.
2 months.
He said it 2 months.
Okay. Percutaneous screw.
Actually, in our department, we started to use the arthroscopic management of scaphoid nonunion, and we noticed that they are heals quite rapidly than the ordinary way of management and then open management. And here, actually, there is no big gap, so it needs a little part of bone grafting or not. So either to go for percutaneous fixation or arthroscopic debridement and minimal bone grafting and fixation with K-wires.
The same advice.
Yeah.
I agree with that. I think the one thing takeaway for our participants is that the arthroscopic management is very attractive. I think with an open approach, we devascularize the fragment even further. And so by doing the arthroscopic approach, that makes that risk much less. And I would agree with what's been said that the healing with the arthroscopic management is does appear to be much faster. That being said, it is more technically challenging. Not everyone has the arthroscopic skills to do that. So I don't want everyone to feel like they have to do this arthroscopically. I think the humpback deformity is very minor. And I think if a percutaneous screw fixation or even a slight mini open fixation with just addition of some bone graft would be certainly a very viable option as well.
Okay. Yeah. Okay. So I did do the bone graft. So I did do arthroscopic debridement and I did do the bone graft, and I harvested from the distal radius. So I forgot how this is. Okay, this is 6 months. So with that, haven't got the CT yet. Forgot what happened. Oh, wait. Yeah. So with that, I'm completely not sure that it's healed, but then that's what the CT shows. So it shows that there's some signs of healing, but maybe not complete. Then I did an MRI. Again, do the same thing. That is not completely healed.
Thank you.
9 months. The patient doesn't have any complaint. I haven't keep on asking me when he can go back to resume playing rugby, and I said that it's not healed yet. So just hold it. So at 9 months, so that's the X-rays. What will you do?
Wait and see.
Wait and see. How long are you going to wait? if it's a year, and how long are you going to wait?
Do you have a new CT scan, Margaret?
Pardon?
Do you have a more recent CT scan?
I did actually. It shows similar things. So yeah, with them are similar. Yeah, 9 months.
One question, please. How is the extension of the wrist in this phase? because probably in this image seems to be a little palmar deformity.
Guys, why do not wave to stimulate? How to say onde d'urto?
Shock wave.
Yes, some shock waves, I think, and could be an option.
Okay, so how long? Yeah, so how long will you wait? So a year, if that's a year, is a 1 year old, how long are you going to wait? How long, much more?
Shock waves and 3 months.
3 months, okay.
Yeah.
Okay, so if this is 3 months later, so what are you going to do?
I think at least in the United States, people are much more impatient. None of my athletes would wait 9 months before they would return to sport. They would leave me and go to find someone else that would allow them to return to sport. So yes. I think it's time to let him try and see what happens. He's pain-free. He's clinically healed, even though radiographically it's not healed, or may not be healed, but may be healed. He's pain-free with great range of motion. I think it's time to stress it and see what happens. And if he goes to rugby and he starts to feel pain, then he knows that, then he and you know that it hasn't healed and it needs further treatment. But if he's able to play rugby, then it's a happy ending and he's done.
Okay. Yeah. So nobody will go for surgery then?
No.
Okay. Okay. So yeah, I discussed with him. So I actually did. So if you go for surgery, I didn't ask you, would you go for surgery? Would you do open arthroscopic? But so after, so I follow what PC Ho says. So he always said that even if the first arthroscopic bone graft doesn't work, don't worry, just try the second one and then it may work. So yeah, so I did the second one. I find that there's partial union of the right scaphoid race and filled with fibrous tissue. I did not actually get the video, but then I shaved it and then I did cancellous bone graft from the iliac crest. So that's 6 weeks post-op. And then that's 6 months. And so it heals now. So that's post-op 1 year. So that's the range of movement. And he doesn't have any.
Do you think you needed to do the second surgery?
I feel better after the second surgery. I don't want him to go. Well, that's the dilemma at that time, is whether I talked to, basically, I think his father is very educated and is very, so I told him the pros and cons. I said, I don't think that you have pain at the moment, so you can go back and try, but then you may need to come back for surgery, or that you go for second surgery and then see, and yeah. And they chose to go for second surgery. They don't want to come back because they can see there's a scaphoid fracture that they don't think that it's completely healed. Yeah, so I don't really know the answer, but yeah. Any comments?
And is your preference always to use pins and not a screw?
I use pins now because I feel that I can pack in more bone graft in the arthroscopic bone graft. So I just feel that it seems as though I can pack more in. Yeah, so that's just my preference. And I think, so PC Ho, I think most of his patients, he actually did bone graft, just pinning. And so, yeah, so that's the preference for me. Yeah, yeah. I did try with screw once. And that failed. So I just have that. So this is just personal preference. I just thought that may be that's because I didn't really put in as much bone graft. And also it depends on the patient's what's the word? How tall they are, the statures. So if they small hands, and I would prefer to use actually to do KY. Definitely.
Sorry, Margaret.
Yeah.
May I ask you if this guy is continuing to do sport?
Yes.
Okay.
Yes, he's returned to rugby. He can't wait. So I already made him miss 1.5 seasons. Yeah. So yes.
But the completed time for the result is how much months?
Sorry, I missed.
How many months for the result?
Total time.
Two year, 1 year enough?
I think, well, the first time, I mean, at 6 months, I actually asked him to wait because I think that there's partial union, so I asked him to wait. When 9 months came, I thought, well, either you resume to sports and see how it goes, or you do another surgery. Because as Jeffrey say, after waiting for 9 months, is that they don't really want to wait. So I think he resumes sports in about one. So from when I first see him, probably a year and 3 months. Yeah. So that's really too long. I think that's quite long. Yeah.
Thanks. The problem for these patients is that when the stop is too a long time, is a problem for the worker, is a worker for this man. And it's very difficult that you say, I stop you for maybe 6 months, because this patient is a contrary for that. For me, that I treat some sportsmen, the great problem is that I say stop. But I know that sometimes it's difficult that you do that.
Yeah.
Is the big problem. And sometimes the result is not good well, because use the hand before that I say not stop, stop for this time. Sometimes move before and arrive to me that I don't make nothing. No, this is a great problem for these patients, very great problem.
Yeah. So
I have a question, please, Marco.
Yes.
My question to the faculty regarding the use of modalities to help bone healing in scaphoid non-union, like the ozone therapy, hyperbaric oxygen, magnetic fields, shockwave therapy. What about your experience in using that?
For me, I don't really use them. I don't
all of the faculty.
Yeah, but then
I have experience about the shockwave and the use to BMP and platel gel and the other things. When I have some patient that I prefer the result is well, I use everything that I have to disposition. And another things I use the screw. The screw for me is too very hard. It's very for me. Sometimes the K wires exit. I find sometimes the K wires out of the medication because it's not compression, not the stability, and is a great problem when you have a man that is little special. I use this experience in these cases. Not to put only bone graft, but also I use also everything that I think that is good for the results. And shock waves also, right?
I use magnetotherapy to improve results, and the shock waves in the case of Margaret show us. So if I have a doubt of there is a fibrous tissue between one part and another, I think it's very useful.
Yes, I agree. In selected cases, shock waves can be a good option. Regarding Ferdinando speaking, I think compression is not always necessary. Then I think if you use K-wire under skin, often you can have the same results as screws.
Sorry, I make a mistake. I don't make compression, because if I make compression, I created another situation that is not good. I use the screw because for me is very stable. It's very stable and very hard. And I know that the distal part is very, very stable for the proximal part. The two parts of the screw is perfect, but not a compression. I agree with you, of course.
May I ask, when you talk about shockwave therapy, is that the same as ultrasound? I'm not familiar with that technology.
No.
Yeah. Okay. Well, since it's now, I think we are overrun quite a bit, and so I think we probably should stop here. Sorry about Dr. Nuno Silva, who is from Brazil. He's actually woke up he turned up a little bit late, so we didn't actually get to allow him to present his abstracts. But then hopefully he can submit it next time in these, and especially in the annual congress in KL next year. So I think we probably need to wrap up this. So thank you very much. And then, so Sylvia, could we have the, could you share the final, yeah. Okay, so we're just wrapping up about some of the key points that we got from these webinars. So it's the classification of the natural history of scaphoid nonunion is from fibrous union to AVN nonunion. Is 90% of the scaphoid nonunion heals with bone graft, and only 10% needs revascularization procedures. So, so the union rate basically depends on the stability and site of the union, age of the scaphoid fracture, and the type of the treatment and revascularization. Next. Yes, open treatment is with stable bone graft, and for scaphoid nonunion, bone graft with stabilization is the gold standard for scaphoid nonunion. So you can either have the volar approach and the dorsal approach. Vascularized bone graft are logically more popular and provides relative better results. Centrally applied headless compression screws produce reduction, stability, and better range of movement and shorter immobilization period. Arthroscopic management of a scaphoid nonunion is less invasive but has a higher learning curve. It is beneficial with associated risk pathology, and it is better to use in non-comminuted nonunion and AVN. Vascularized bone graft in scaphoid nonunion, the advantage is that the consolidation is more than 90%, and we can have possible harvest in the same location with plexus and ECACs and anesthesia, and the consolidation times I estimate 6 to 10 weeks. The disadvantage of vascularized bone graft is longer surgical time, more complex surgical techniques, and smaller dimension of the graft. Treatment for the proximal pole for the scaphoid fracture with vascular problems, it can have non-surgical interventions as well, and the different techniques depends on the patient and the time elapsed between the accident and the intervention. So both it can be done in both open and under arthroscopic control. For the unsalvaged proximal pole scaphoid, we can use rib costochondral autograft, proximal pole handmade autograft, and the medial femoral condyle. Yes, and the non-union for skeletally immature scaphoid fractures, we have high index of suspicions. You need to have high index of suspicions and obtained appropriate radiographs. As a good number of these are frequently initially unstable, so we need to do internal fixation with or without grafting. For unstable and displaced fracture, cast immobilization alone may not be enough and prone to complications. So nevertheless, surgical treatment for non-united scaphoid fractures in children and adolescents is a successful surgery without complications. So thank you everyone for listening, and please fill out the post-webinar survey and receive a personalized certificate. And the next webinar, don't forget, is the research and what can we achieve, and it will be on the 11th of December 2021. So with that, thank you very much, and thank you all the faculty. I know that Jeff is in past midnight in your time, so I'm really sorry. Thank you very much for joining. Thank you very much. Thank you, and the others.
Thank you from our society. Thanks for our society that invite us for this webinar, and thanks to SICOT also for invite us in this webinar. Thanks so everybody, the speakers. Very interesting webinar. Thanks a lot for everybody. Thanks, Margaret.
Thank you. Thank you. Bye-bye.
Bye-bye.
Thank you, everyone.
Thank you very much.
Bye-bye. Thank you.
Bye.
Bye.
See you soon. See you live.
Everyone.